Hello and welcome. This is the Butte-Glenn Medical Society virtual Grand Rounds. I'm Christy Burden-McKeeve, the Executive Director of BGMS. I don't need to go through all of the online meetings protocols. I think we're all used to it by now. Today is March 24th, 2022, so it's been 2 years. Just to make sure that you keep yourself muted unless you're speaking, just because sometimes there's background noise. I think Dr. Yu is going to do a fairly interactive presentation. We are recording the presentation, and I just wanted to say that if for any reason you have technical difficulties, it's good to sign off and then sign back on, and that usually resolves the issues. A huge thank you to Enloe Medical Center for providing CME. Dora Anderson is on the call today, and so she'll be following up with me and then with you with email on the CME process. So today we're very happy to have Dr. Kim Yu from Aledade speaking about value-based care. It's a phrase that I've heard for several years, and just really excited to get some more insight on it and make sure that we are all moving in the right direction, because value-based care can be something that is worthwhile and actually productive and can help you earn some money, I think. Dr. Yu will explain that much better. I'm going to stop sharing my screen. And while Dr. Yu is setting up her slides, I just want to say hello and welcome. We have Dr. Andy Miller, who is with Enloe Medical Center. We have Dr. James Schlund, who may or may not be in Tahoe or in Chico, depends on the day. Radiologist. Are you here or there? You're here, okay. And then Denise Gontes, who is, I'm not familiar with you. If you want to introduce yourself, Denise, please unmute.
Hi, I don't know if you can hear me.
Yes.
Okay, I'm a nurse practitioner, and I recently came back to Chico and Enloe Medical Center, and I currently work for general and colorectal surgery.
Okay, welcome back.
Thank you.
That's very helpful. It's really good to know who's on the call. And so, yeah, feel free to put your name and your specialty in the chat so that I know exactly who to try and tailor this for. But most of this revolves around primary care. A lot of the work that we do in value-based care really stems in primary care. So I apologize ahead of time if this doesn't seem as curated for radiology or colorectal surgery, but I'll try and bring in multi-specialty as well as we talk through this. So again, my name is Dr. Kim Yu. I'm a regional medical director for Aledade, and I've been working at Aledade now for over 2 years. I'm a family physician by specialty. I'm also the current president for the Orange County chapter of the California Academy of Family Physicians, and also on the delegation to the AMA for AAFP, the American Academy of Family Physicians. So really excited to work with Butte-Glenn, and I want to thank Christy for inviting me here to talk to you today about thriving in value-based practice. Disclosures, as I said, nothing to disclose except that I do work for Aledade. We do value-based care work. But our objectives today are really to consider the values, the basics of value-based care, what really matters and how to really thrive in independent practice, how to evaluate your practice, your workflows, and share ideas to improving outcomes for patients, identifying barriers and blockers that hinder advancing of value-based care, and developing a really concrete action plan to bring home to adopt in your practice. And as I said, it may differ a little bit if you're looking at subspecialty, but many of these things really do cross across all specialties. What does a practice need to thrive? And we all need stable financials. We need to have the right resources and have staff. With COVID, not only have we lost staff through the pandemic, but it's become increasingly more difficult to keep staff. And I'm sure that you're seeing that in your practices in your hospital. Morale is at an all-time low. And we know not only in terms of physical health with long COVID and other issues, the emotional health and mental health and well-being of our physicians and staff, nurse practitioners, PAs, and office and hospital staff has really taken a hit. We need to provide that safe physical environment. What about our patients? Our patient volumes in general have dropped anywhere from 20 to 40%. And so knowing how to leverage innovation and technology, health IT, data, telehealth, et cetera, really is very helpful during this time period to figure out what we need to do to thrive. And there are other things that will go as we go along. So the shift to value-based care is really stems from the fact that we have this huge spend, $3 trillion in annual healthcare spend with over $1 trillion of waste. It's almost like this large waterfall that you can see here of money that is just spent on healthcare. And it really is a disease system that rewards disease states rather than prevention. We know that primary care physicians are in a unique position, but all physicians are in a unique position to really reduce waste through value-based care, whether it be on unnecessary services, administrative costs, inefficient care delivery, prevention failures, or fraud. You can see all the breakdowns there. But it's interesting to really sit and think, well, I don't really provide unnecessary services. I mean, how many physicians would say, I provide unnecessary services? Put your hand up, right? We're not going to do that. But it is important for us to actually look at that and say, well, okay, hold on, let's have a look at this. What are the administrative costs? What are the unnecessary services? Where are we providing inefficient care delivery? And what are the systems in place for us to be able to evaluate that and really find it? We know that fee-for-service is going away slowly, and primary care is really shifting from volume-based to more of a value-based system. And so you can see here the amount of money and revenue that physicians in practice are actually receiving fee-for-service has decreased and declined from anywhere. It used to be in the high 90s fee-for-service, and has decreased now to around 80-something% and decreasing even more. CMS's goal is actually to have more value-based care rather than fee-for-service, and that's why you're seeing this decline over time. So it's imperative that we really move our frame and shift from looking at volume to value. You can see here that value-based care really rewards doctors for the care that they're giving and really the quality care that they're giving, whether it's on this sort of spectrum from fee-for-service all the way to paying for success with outcome-based payments. You can see there's an increased level of risk as you go across this slide. And so whether you have volume-based payments, which are the traditional fee-for-service, or these performance-based programs, the P4P type programs, versus the bundling that you will see a lot in other specialties where there's lots of bundles associated, versus the capitation, shared savings, shared risk, et cetera, in the ACO programs, and then these outcome-based payments. When you look at value-based payments or alternative payment models, we can stratify into these four main categories: the fee-for-service with no link to quality and value, fee-for-service with a link to quality and value, and those are those pay for performance or rewards and penalties, the alternative payment model, where you can get an upside where you share in any savings that happen, and also these population-based payments, which are comprehensive based payments that are condition specific, or for example, based on the index, the health index, social vulnerability index of a population. I'll give you an example. In Maryland, I went to a meeting, I was speaking in Maryland, and they have a fee that is actually given to primary care physicians for their high need patients, really super high need patients who live in certain zip codes, and they would get an extra little bump for that. So that's a population-based payment. When you break it down further, you can see the amount, and this is from 2019. So the data's changed a little bit from here. It's increased more to the right, but not that much more. So you can say about 39% are in the traditional fee-for-service, 25% in some link to quality and value, 30% in this APM, the alternative payment models, where they have upside and also downside risk, where they actually take some of the sort of whole payment, and if they don't reach the benchmark, if they don't get shared savings, they actually may have to pay back, right? So there's a small percentage, about 10% who are in that upside and downside high risk, and then about 5% who are in the population-based payment. So combined about 14.5%. So you can see this gradual shift to the right, which is changing the way that we practice medicine and really how we do what we do in primary care. When we think about all of these different models, I like to talk a lot about the Medicare Shared Savings Program. It's the most traditional and the most stable out of all the alternative payment models that are out there. This is a basic 5-year program that is called the MSSP program. And do you want to, anyone in any MSSP type program at all? Let me know in the chat. But what we see here is you can go from a basic A all the way to enhanced, and each year you go along the track. Now, there are some practices that may be very advanced in the way that they practice, and they may be able to jump straight into a basic E or an enhanced track. But the difference is this: CMS will actually, Medicare will actually, in basic A, there's only upside. So if you save money for Medicare, they will share 40% of those shared savings with you, right? With the ACO. And there's no downside whatsoever. As you can see, as you move to the right, that upside goes up from 40% to 50%, from 50% to 75%. 75%, as you can see, is much bigger than 40%. And so you really do want to ensure that practices move along to two-sided risk. The problem is that there's a downside to that. If you don't get shared savings, which can occur, and you don't get shared savings, there's a downside and you may have to pay back. There is a risk cap where, you know, the downside, it says 30% in basic E, for example, there's a cap. It says 8% of your fee-for-service revenue. So only 8% of that would be at risk. I know it's a lot of words. The good news is that there are some companies, and Aledade is one of them, where we cover all the risk. And that's one of those important questions that I always ask people to ask is, if you're in different models of care, always ask the question, what about risk? Am I on the hook for that? Or do you cover the risk? Because that is really key when you're making any arrangement with anyone. So really important question. Direct contracting, and many of you may have heard of DCE. Direct contracting was Medicare and CMS's complex attempt at delivery system reform. It is much newer than MSSP, and it actually didn't do well. It didn't do well, and CMS realized that it wasn't doing well, so they've actually rebranded and changed it to ACO REACH. ACO REACH is very complex. When we looked at it, it just came out literally this month. And there are parts of it that look great. It's definitely something that we're looking into. There's parts of it that really need a little bit more information, need a little bit more clarity. With DCE, there was much more difficulty in getting to the benchmark. That hasn't been clarified, that the benchmark would be easier to reach with ACO REACH. And we're still wading through all the information to be able to provide that for our practices. But I really want to stress that even though there are health equity is part of it, I'm actually the chair for health equity for the World Organization of Family Doctors, the special interest group in health equity. And so when I saw that they were adding health equity into this program, I was so excited. The issues about that are, it's still very difficult to collect the data. If you've gone into social determinants work, it is so difficult to collect data, and that collecting the data for health equity work is very burdensome and actually costs money. So there's some infrastructure that really needs to be built when you look at ACO REACH, which requires a lot more investigation. So again, ACOs, they're a group of healthcare clinicians who really work to deliver coordinated care. And so we see that ACOs have the potential to lower the quality of, lower the costs of care but improving the quality of care. And so whether it's with hospitals, other clinicians, specialists, nursing homes, primary care physicians, there is an important level of being able to report all the levels of performance, meeting those benchmarks, and really keeping together and working together on reducing the total cost of care to ensure that patients really have the care that they need. When you look at physician-led ACOs, they actually dramatically outperform hospital-led ACOs. And this is not surprising in some ways, but we call them low revenue versus high revenue ACOs. And this is data from CMS. You can actually see that physician-led ACOs actually outperform large system hospital-led ACOs, and which is really interesting. And at the same time, allows for opportunities for smaller hospital systems or smaller healthcare systems to really think out of the box of what it is that they could do to really elevate and ensure that they're not getting $26 below the benchmark per beneficiary, right? That you're getting more than $180, $200, $300, $400, $1,000 per beneficiary in shared savings. And so, and we'll talk more about how do you really get there? Is it possible? So the path to success in value-based care, really there's many different assets and different ways in which you can see this in this roadmap. And I like to take people on this roadmap because there's a lot of thought that has to go through this roadmap to value-based care. The first is really assessing your motivation and goals, really understanding what is the reason why you want to do value-based care, and are you really set up for it? It's making sure that your goals align with the mission and vision of whatever your practice is, your organization, your hospital, whatever system it is, that it's all aligned. The second step is really about training, education, and workflow redesign. There is definitely a sort of uphill battle of ensuring that everybody is on the same page when it comes to value-based care. You can't just implement something and expect everybody to understand immediately we're going to be doing TCMs differently, or annual wellness visits, or ED follow-up. There has to be a lot of education that occurs and workflow design. We need to be able to prioritize the delivery of proactive care. So reaching out to patients and ensuring that they get the care that they need ahead of time before they realize even sometimes that they need it, right? Can we evaluate that? Can we ensure that we pick that up? And really developing those meaningful partnerships with organizations and resources like Butte-Glenn Medical Society. Having those partnerships and being able to learn from peers is critical to being successful in value-based care. I can't tell you how many times I've spoken to practices and physicians where they say, oh, I was in an ACO before, but I signed a contract and that was it. I didn't get anything else. And I was just heartbroken because there should be support. You need support to be able to do value-based care. In many ways, being prepared to live in both worlds of fee-for-service and value-based care, some have said it's almost like you've got feet in, your 2 feet are in different canoes, right? You're trying to navigate both. And this was information from Deloitte that actually showed that 50% of physicians are aware, which means 50% are not aware of the cost of treatments and tests they select. 48% are comfortable discussing the cost of treatments and tests. 64 consider, do have the information and are able to try and make that decision between cost effectiveness between different treatment decisions. And most, 3/4 say they try to consider non-clinical circumstances when making treatment decisions, but it's not easy. And so looking at that information there, it was really important for us to really realize that we need to provide the information. So do you know how much it costs for an MRI or a CT scan or anesthesia for, whatever it is that you're getting done? Being able to track that and really provide from the patient and physician perspective that information so that they can make the right decisions. This is a value-based care focus that we really see a lot of value in and really is core to the work that we do, whether it's access and quality work with transitional care management and annual wellness visits, care transitions with ED visits and TCMs, risk stratification with looking at care gaps and understanding the patient and documenting how sick a patient might be. And then Care Compass is actually part of our new part where we have a Aledade Clinical Services where we look at advanced care planning and high value specialty referrals. So looking at all of these different assets along with using technology, which you can see on the left, to be able to provide all the information so people know what's actually happening to the patient outside of the four walls of that primary care doctor's practice, what's happening at the hospital, what's happening at Enloe. I want to know what's happening at Enloe. And, who are the docs who are doing all the different things there, right? And being able to provide that to the physicians in the community so that they can really concretely see, oh, that's where they went for oncology services. Oh boy, I didn't know that Mrs. Smith actually had cancer. Wow, look at that. And that's what the test they're having. So being able to bridge that gap between the services that are being received outside of an individual practice is valuable for patients. And until we have integrated HIE in California, we continue to need this work. Here's some of the savings, and you can see different ACOs across the country and the amount of money that they've saved, but more importantly, the type of work they're doing in terms of reduced ED visits, reduced inpatient hospitalizations, and the quality that they've been able to provide. So you can see that value-based care can really help with reducing unneeded care in the hospital. Now, some of you who may be in emergency medicine may think, well, I don't want decrease of 22% in my ED. But I will say that, what we found is that the care of the patient really, in many ways, seeing the elevation in care that patients get is so very important, right, for all of us, ensuring that you don't have return visits to the ED and readmits, etc. This is quality scores in the Medicare Shared Savings Program, where you see through 2017 to 2019, there was a 20% improvement in A1C control, 9% improvement in blood pressure for hypertensive patients, and 93% of patients rating their clinicians highly compared to the average of 92%. But, that's still very high, right? We want our patients to rate us highly. This is actually about quality reporting. I don't know any doctor who say that they like having to do quality reporting. And this is just information actually from the AAFP that shows that 60% of family docs say that they have contracts with 7 or more payers. They spend 12.5 hours a week that staff spend submitting quality measures, which comes down to 2.6 hours that a physician spends submitting quality measures, which comes to 758 hours per year per physician that a medical practice spends submitting quality measures, right? I don't know what that's like in other specialties, but I'm sure that it's pretty significant too also. But you can see the cost there. So really thriving in practice and how to succeed in ACO comes to all of these things: picking the right partner, making sure you ask those hard questions. What are the fees? There are some ACOs and value-based care partners that do charge upfront or take, like DCE, they actually would take all your Medicare, like everything you would get from a 99213 visit. They would take all of that money and give you a certain percentage of that. And that would vary according to different DCE companies that are out there. And so, instead of it being like a 50-50 split, maybe, they would totally like give you only 10% back. And so it was horrifying, actually, some of the things that I've seen happen. So it's really important to see, are there fees or not? We don't have fees for using our technology at all. So what services are provided? Is there special technology that will help me do value-based care? Are there field teams support? We have practice transformation teams, local medical directors, regional medical directors. We have board meetings and clinical calls to help practices do the work, and then weekly meetings to help the staff do value-based care work. So having that support. How often do you interact with the ACO? Is it hands-off or hands-on? And did they make shared savings? Is their success rate? What are they doing with population health? Is it physician led? Is there physician autonomy and independence? And how easy is it really to reach that benchmark, and do they cover the risk? Change management, I won't go through this, as we know that change is really important, but really implementing change management within a practice is vital to being able to do value-based care work, and really having someone assigned to help lead that can be very helpful as well. Evaluating practices really involves all of these different steps, whether it's picking a champion, having process improvement where you do PDSAs. You could even do business process reengineering where you can use tools for that. And if you're a hospital system, hopefully you have something in place where you do have a tool like iGraphics or something like that, where you go in and you can track all the different processes that are available to be able to tweak how long it takes for someone to walk in the front door and get out. They're really fun actually to tweak and play with the technology that's available. And then getting secret shoppers involved, getting patients to go in to really see what it's like in your practice. Having patient advisory councils can help as well. So this is the time where I actually go into some polls, and I wish I could do a poll. I wasn't able to deploy it in here, but just in terms of A, B, C, or D, what is the largest barrier to achieving efficiency in primary care? Maybe in the chat, you can say what you think. And maybe, you want to also say, I don't know about primary care. What about in your specialty? What's the largest barrier to achieving efficiency in your practice? I'll wait and give you a few moments to get in the chat, and you can put in your answer. Is it capital, return on investment, physician resistance, technology and data efficiency? Or you can shout, you can come off mute and let me know. Because there's only a few of us here, so feel free to come off mute. Dr. Miller.
Yeah, so I was going to cheat because I'm a doctor and we all come up with our own rules, don't we? So I'm going to answer with the largest barrier to achieving efficiency is a payment structure that does not support efficiency. Payment structure, cultural history, the whole infrastructure doesn't.
Amen.
So I don't. For me, it's not really falling into. I want an E, and so I'm going to suggest.
You can make an E. You can absolutely.
Thank you. I appreciate the freedom.
That's great. Thank you. Anyone else want to share? Dr. Schlund?
Oh, I'm in I'm in a radiology practice, largely hospital-based. Our infrastructure issues with regard to health information and IT are the crippling pieces on efficiency. That there are hospital information systems that cannot clearly tell you what the patient is struggling with, and that we spend a lot of time filtering through the HIE trying to figure out what's wrong.
Yeah.
And then we also have IT issues, administrative issues where administration is disconnected from the actual workplace. They don't stop in, they don't actually know how the work gets done.
Yep, absolutely. Thank you for sharing. Denise? Not sure if Denise is able to come off mute. Give her a few moments. It's really interesting when I've done this poll in different groups. We've actually seen any of these. There's no wrong answer, right? But the most common is actually C, physician resistance to change. And so, it is interesting that is being seen as an issue. C and D usually are pretty equal, but oftentimes C comes out ahead. And it's not just physicians, it's clinician resistance, like staff resistance. Denise, did you want to say something?
Yeah, sorry, I thought I was unmuted and I wasn't, so I apologize. I've worked in a variety of between family practice, internal medicine, and with some different areas where we had to work with the resistance, and the physician resistance was definitely great, especially with some of our physicians that were close to retirement and the change. And then, of course, the technology and data issues. I don't think the return on investment was too much of an issue, but getting people to just the buy-in. And but when I did family practice, we found that it worked very well, actually.
That's awesome. Thank you for sharing. What about this one? What wastes the most time? And I have it in primary care, but since we're radiology and anesthesiology and general surgery right now, what wastes the most time for you? Is it inefficiencies during appointments and scheduling? Is it patient phone calls, insurance verification, or practice layout? What do you think? Dr. Miller.
Yeah, I will answer your question with one of the answers, and then I will say practice layout.
Okay, that's great. You are welcome to add another E too, if you had another one, but how about Dr. Schlund?
In talking to my primary care colleagues, it may not be the most time wasteful, but it is the thing that creates the greatest amount of consternation, and it is authorizations. And the workarounds required by the bureaucracy in order to actually do care. Absolutely. It's the amount of patient-facing time is something that they desperately want, and the bureaucracy that keeps them from that time is what they talk about.
100%. I know that if I put E as prior auths, that would probably be the number one for sure. So yeah, definitely. Denise.
Yeah, definitely the practice layout.
And that is really interesting that you both have said practice layout, because that in most conferences that I go to, they will say it's A and C, right? They spend a lot of time doing a lot of A and C, and they don't realize that it's actually D that wastes the most time. And when you look at practice layout, I was at a practice where I actually counted steps. I don't know if you've ever done this before, but I actually counted the number of steps it takes for the patient to get in and out of the practice, and how many steps it takes for the clinicians to actually do their work. And what we found was just by moving the printers into each room, having a printer in each room instead of having it just at the front desk, because what was happening was that the clinicians were actually walking the patient to the front desk to get the papers that they needed to check out on, and then would give it to the patient, because that was a nice thing to do, right? You want to have that handoff, that warm handoff to the person making the appointment. So they would walk them all the way, but that step was actually costing them at least 20 to 30 minutes a day each, when you calculated how much time they spent walking backwards and forwards. So just doing that one thing really helped with saving a bit of time.
And Dr. Yu, if I may, it's interesting that you put practice layout as physical layout. I thought of it as philosophic layout. And I have struggled ever since I have left Indian, a tribal health entity where we were able to utilize people in teams and push tasks out of the clinician's hands into very qualified people, because it wasn't all about payment. And then I watch how much gets filtered to the clinicians in most practices because of payment, again, because they have to be the ones performing X, Y, or Z, either legally, billing wise, or even culturally,
Right.
instead of, so that's the practice layout I meant.
Yeah, and definitely, having an efficient team, team-based care is crucial and critical to it doing primary care and value-based care in general. So you're absolutely right, 100%, 100%. I want to touch on some of the workflows and barriers, and here are some of them that we see in primary care a lot. Not only the front desk, but phone triage, rooming, getting vitals on the patient is often a barrier for many. Do you decide to have one place where you get it and you get a backlog of people waiting for that one chair? Or do you do it in multiple places, or do you do it in the room itself? So there's lots of different ways in which you can really increase efficiency just from just those first three. Telehealth, there are certainly barriers to effective telehealth, not only because of resources and patients being able to access telehealth effectively in rural parts of the country where they don't have good internet access, or they don't have the money to pay for access to telehealth services. So that's definitely a barrier, right? And how do we really reach patients when they don't have effective telehealth? So that's another area that needs work. ADT, HIE, as you mentioned, Dr. Schlund, is a huge issue, huge issue for our docs being able to get adequate, effective, time-sensitive information from hospital systems or other labs, nursing homes everywhere. Being able to get that is critical to doing value-based care work, and making sure that it's paid for. I'm on NQF's National Equality Forum's EHR care coordination, EHR measures care coordination and communication committee. It's a mouthful. And I spent, I've been on this committee now for a year and a half, and it's really fascinating because they were wanting to move everything to EHR-based measures instead of claims-based measures. And it almost gave me a heart attack because I sat there thinking to myself, oh my gosh, if you move it just to EHR measures, you're basing it just on your EHR, which might be owned by different systems that don't give access to some of the doctors that are out in the community, and so from an access standpoint, they may even charge the physicians for access to the data on the patients that they take care of. And so it becomes a real complex issue when you're trying to do value-based care work. EHRs, as I said, lots of difficulties in terms of ensuring the data is in the right place. If you just have one field and the blood pressure is not in the right place, you won't be able to get that for your quality measures. Everything that you can see further on is a lot of it is to do with how do you deal with staffing and what you do with ensuring that patients in terms of ED visits, hospitalizations, and all of that type of stuff are managed, right? How do you manage those type of visits? And then thinking about workforce and pipeline. Christy and I have talked about this, especially because of the work that Butte-Glenn's been doing in healthy rural California. We're just so proud of the work that's being done to ensure that graduate medical education is really highlighted. And, from a California Academy of Family Physicians standpoint, we've been asking for extra funding for Song Brown so that we can have robust primary care in communities. We've also looked in Aledade at how we can help residents who are in residency, if they sign up with a practice who are in independent practice, or in a community health center that's with Aledade and doing ACO value-based care work, that they would get funding through residency and also training in residency, right? Being able to get that type of sort of additional funding sources so that your pipeline to your practices is strong. It's not just those who are getting the rural, rural funding that's out there. But if we can get funding to all docs, for all docs, that would be incredible, especially in our rural areas. And I see Christy's got her thumbs up for that. So action plan, I wanted everybody to be able to have an action plan. Your actions, you need to state your goal, have action steps, have criteria for success, and obviously team members involved in the time frame. That's what we want. I look at things in terms of these additional areas. So I'd already mentioned several before, and I have to move several things around on my screen because I now cannot see certain things that are there. So excuse me while I talk over a few of these things. So telehealth, chronic care management, behavioral health, ADT, finances, and whatever is in the top right corner. Someone shout it out for me because I cannot see. Can you see what is in that top right corner?
Are you asking about what's over on the furthest right side, transitional care management and finances? Is that what you're asking about?
Yes, I can't see because
Yeah, those are the two on the right-hand side.
Yeah, there you go. Thank you. I can now see now. Telehealth things, what not to do. Obviously, we know poor lighting, poor sound, poor Wi-Fi, and poor communications, a no-no. There are resources available for physicians in this telehealth toolkit. Most physicians obviously have mastered this right now with the pandemic, but I wanted to provide this for you because there's some really cool things that are mentioned in there, including the use of translators and how do you really effectively get translators in, ahead of time to be able to ensure that they're ready for that telehealth visit and not spending 20 minutes trying to wait for the translator. Chronic care management is also an area that is of importance for doing value-based care and also primary care in general. And so why is it important? It also gives patients the support they need between office visits. This goes also towards payment, change in payment models and how we really pay for the care that we're providing our patients between the time they see us. And so being able to provide those extra resources for your high need patients can really help with improving patient care. Documentation is provided here with the things that you need to document. And I'll be providing these slides to Butte-Glenn and to Dora so that she'll share it with you. I wanted to provide the CPT codes also available for those that do complex and non-complex chronic care management. It's definitely something that should be done by primary care physicians in a manner that really you track. You can't just do it and kind of fudge the numbers. You need to have evidence that you are actually providing the care. And so I often do a workshop on this, just on chronic care management, where we talk through all the different coding and what you need to do to be able to say that you did what you say that you did. What about chronic care management with telehealth? Can you do it? And the answer is, if a patient isn't, yes, you can. And if a patient who's enrolled in chronic care management comes in for face-to-face E&M visit, can a minute spent working on non-face-to-face after the patient leave count towards chronic care management visits? The answer is yes. Once the patient leaves between visits, the time spent is counted. What about transitional care management visits? These are visits that are done after the patient is admitted to the hospital. The initial call needs to be within 2 business days. And so that's critical. If you don't do it within 2 business days, you can't get those visits. What we know also is that transitional care management visits really decrease costs significantly. And only about 5% of, let me see here, I'm getting my notes out here. Oh, for chronic care management on the previous slide, only 5% of physicians are actually billing chronic care management for at least one of their beneficiaries. And, if you're in an ACO, you're more likely to do chronic care management. With TCMs, even though more physicians are doing transitional care management, probably about anywhere from 30 to 40% do transitional care management visits, but they're only doing it on about 22% of their eligible patients. And our goal is to do at least 50% in our practices to ensure that our patients are getting the care that they need in between hospitalizations. Behavioral health, big need for our patients, especially right now. These are 2 companies that we work with, Mindula, and Constant Health is also one that's very similar. but they provide behavioral health services to patients through our ACO that is really outstanding. So they have psychiatrists, psychologists that help us. And this is evidence for the work that they do. There's been 80 randomized controlled studies that have shown that when you have really good behavioral health care, it not only reduces depression, but also decreases costs, as you can see with A1Cs, blood pressure, and cholesterol. So those notifications, those ADT, admission, discharge transfer notifications are really important. Are you getting them? How do you get them? When are patients admitted, discharged? When do patients go to the ED? When do patients, if they get a COVID positive test, do you know that? We provide all that information for our practices, and it's been life-changing for them. I had a practice who had to, their office manager would run around to each doctor that was rounding. So they had hospitalists, and they would need to know, well, who's discharged? And they didn't have very accurate feeds from the hospital, unfortunately. They would get facts with who would get discharged, but sometimes they'd be late. And so the office manager would spend probably at least an hour and a half every morning to 2 hours running around to 11 doctors trying to ask who was discharged, who was not, what's the plan, when are they coming in, blah, 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 blah. We showed her what we had for her in these work lists, and she was just like, oh my gosh, you've just saved and transformed my life. Like, this is transforming the way that I practice and the way that we do stuff in the office. So now she's got an hour and a half, 2 hours back to be able to do other things. Using technology, patient registries, being able to identify those high-risk patients, those no-shows, getting data extracted from your EHR, using population health tools, patient portals, all of these things that are mentioned here. The digital assistants, whether you use Scribes, Suki, Decoded Health, those are also more technologies that do work like a virtual resident. Lots of these technologies can be used and also elevate the work that you're doing in primary care, value-based care, or even subspecialty care. So really some practice recommendations. I know we're close on time. I want to be able to provide time for questions and answers. So all of these practice recommendations, you could ask your practice. Do you have an EHR champion? Who is the informatics officer? How do you interface with local hospitals? Do you have super users and templates? Are there innovations in workflows? We love working with local hospitals that are smaller and want us to help with integrations with practices. And so we do all of the HIE integrations with our practices for free. And so they love that, and being able to get that information to them in a timely manner can really help them get all the information about their patients. Financial tips, and obviously knowing and billing and coding correctly is a given. You need to audit yourself, ensuring that you understand collections and what your collection rate. I don't know how many docs that I ask them, what's your collections rate? And they look at me sort of blank faced. Well, I know that my bill knows. I'm like, oh, you kind of need to know. So we need to really ensure that in terms of collection rates, knowing what your payer mix is, how much Medicare, how much Medicaid, what commercials you have, how much everything costs. All of these things can really help you in ensuring things are streamlined and very tight when it comes to the financial benefits for your practice, and really evaluating the cost of care of your patients. Do you know who the high cost patients are, and is there a plan in place to be able to help those patients in any way? So again, I said, what does a practice need to thrive? I said all of these things earlier. And at the end, I'm adding you, because you are really what a practice needs to thrive, right? Whatever your specialty, it is truly you, the clinician. You. But you may say to me, Dr. Yu, I'm not thriving. I am definitely not thriving. I'm still not thriving, right? And I did not know when I did this deck many months ago. I picked this sunflower because I love sunflowers, but obviously now it has a different meaning. And we're suffering. Everyone's suffering throughout the world. And, I looked at this Kubler-Ross grief cycle and tried to figure out is there something else that we're missing? We've gone through so much of this grief cycle the past 2 years. But really, there's a 6th stage of grief that Kessler, who's a psychologist, coined, and that is to find meaning. Whether we're, in anger, depression, bargaining, acceptance, and going back to anger again, but finding meaning is really where it really can help. And when we think of self-care tips, I like to think of these 4 R's and an M, where, finding meaning at the end, but self-regulation, and we could do a whole workshop on just that, of how do we self-regulate, how do we really ensure that we have right thinking and reframing, how do we get respite and rest and nurturing those relationships. But self-regulation making all the difference between feeling stressed and overwhelmed and realizing that I can control how stressed I was feeling, and then ensuring that we verbalize together. And so I really thank the Medical Society for allowing us time to really sort of verbalize together a little bit, name it together, what it is to really thrive in practice, what it means to really check in with each other, to be in community. And I was at the OCMA headquarters. OCCFP had our first in-person meeting of the year, of the past 2 years. It's the first time, right? And we had close to 60 physicians show up at this meeting, family physicians, and I can't tell you how impactful it was to be able to be in community again, to be able to be together, to know that there's someone else walking through these exact same moments together. So, and I like to share this Ikigai, the reason for being. It's the combination of your passion, mission, profession, and vocation, and what you can be, what you love, what you're good at, what the world needs, and what you can be paid for. That's your Ikigai. That's your reason for being. And, for each and every one of us to really figure out, no matter whether it's value-based care, no matter what the payment structure is, this is really where it's at. What is your Ikigai? What's your reason for being when it comes to medicine? And lastly, never forgetting the patient, who is at the center of your mission. So I have here some top 10 things. I'll leave it there just so everyone can see it. I'm not going to read it, but I think it's important for all of these strategies to pick one thing. If I could just share with you just one thing out of this top 10 and see if it's something that you could implement even this year, whether it's setting goals, whether it's really seeing if value-based care is a fit for your practice or your hospital system, whether it's, understanding annual wellness visit rates or marking the progress that you're already doing. Maybe you're doing great. Maybe this is old hat to you. You're looking at this and going, dang, Dr. Yu, I wish you dug deeper, given me more. If you want more, just let me know and I'll be happy to give it. But really ensuring that your staff have good morale, maybe that's it. Maybe you need to learn how to whack the work after clinic, all of these things. Pick one thing and see what you might want to do. So I'm going to turn it back to everyone here and say, any questions, thoughts about this? Are there any things that resonated? Maybe you can put it in the chat too. You can type one word that you think of as we come to an end here. And I'm going to take that silence means that you
I have questions. If you know me, Christy knows me, Jim knows me, I'm going to have questions. So you're a person that is involved in the transition from fee-for-service to risk-based, affordable or accountable care organizations, and you're also interested in health equity. So let me ask this. The whole risk-based payment and being able to risk stratify and pay based on that, do you have confidence that we're going to do that in a way that we don't leave our most vulnerable people out?
Yes, because if anything, what I've seen in the work that we're doing and also others that are doing value-based care work is that health equity work is all person work, right? And we are really reaching out to and identifying our most vulnerable patients for care. So whether it be in the chronic care management modules, where we're actually identifying the patients that really need that extra wraparound services, And then having special tags where we actually are able to tag that this patient has transportation needs or has language needs or has whatever, food, is homeless. Like all of these ways in which we're able to stratify and ensure that those patients are getting extra elevated care can help. When I told you early on about the population-based payment model that's coming out of Maryland, that is in many ways very exciting. I mean, from a sort of population health standpoint, health equity perspective, I know that the American Board of Family Medicine and AFP and many in the primary care world are seeing that as something where we can help our practices help take care of the most vulnerable, right? In a much more concrete way, to find the resources those patients need to pay for the medications, to make sure they have the transportation, to make sure that they have the extra visits that they need to be able to take care of all the things that they require. So do I think that it's a better system? I do, because it really is patient-centered, but also ensuring that there's a line of sight of how much everything costs, so that we understand that this patient who is most vulnerable, who may be the most costly, right, that they are also getting all the care. Like it drills down. It's like it'll tell me, I'll give you an example. We've got an ACO that we looked at their ED visits and found out 50% of their patients had COPD, right? We're able to actually find that, wow, 50% COPD. We did an intervention, taught our clinicians all about COPD, what to do, make sure those patients had the resources they needed, the extra steroids, the inhalers, antibiotics, whatever they needed. Now we don't have that anymore. They don't make up 50% of our ED visits. We have UTIs now because everyone's home doing things that he shouldn't be doing and getting UTIs. So, we're able to do that, and we're able to identify of those 50%, who are our most vulnerable patients? What else do they need, right? And I never had that before. I was never
Right.
able to identify those patients in a very concrete way. I knew them the back of my hand, like Mrs. Smith, Mr. Jones, those are my high need patients. But I wasn't able to really concretely identify, oh, Mr. Jones actually has high blood pressure because he only has 30% of prescriptions that he's actually filling at the pharmacy, right? I'm able to give that information now. So I'm excited. I really
Yeah.
am.
So I share your excitement. I'm more of a population health doctor at this point than I am an individual health doctor. And I share your excitement, but I always do. And I don't mean this as resistance, because physician resistance was option C. I don't mean it as resistance because I share your excitement, but I think it has to be done carefully and thoughtfully, because when you push risk down, you also risk having abandonment be one of the options that people manage their risk by, right? And so setting up incentive structures so that those people that need the most care that you just described, and you described all of the positive side of that equation, and I agree with you. There is a negative side to that equation, and that is people trying to get them off of their roles. And we just have to be
not what we want.
Yeah, we just have to be cautious in that space. So I'm glad that you're so hopeful, and because you have more experience than I. I hear a lot of work about prevention. It all seems understandably secondary and tertiary prevention. Where do you see primary prevention falling in this world? Not something that's easy to cost benefit your way into or out of.
So you're talking like smoking cessation and that type of stuff?
No, yeah, so I'm talking more like more population-based work to try to help with diet, exercise.
Exercise.
Yeah, so I think of smoking cessation as people who are already smoking, so have been identified, and then there's an intervention. So I think of that as secondary prevention, and great work, and the kind of work that these organizations should and could be doing. But nobody moves into the primary prevention realm very easily. So I didn't know if it's too much to ask, and it may be.
No, not at all. Not at all. I mean, for us, we are looking very much at weight and there are population health tools that are out there. Health Landscape is one that I love that has actually been built by the American Academy of Family Physicians that will by zip code and by area city, you'll be able to see how many percent have weight problems, how many people have no teeth, how many people have poor sleep, how many people exercise, how many people, all of those type of things that we want to try and impact. And so many of us are trying to ensure that our practices have that information and use that information to really build and create programs for that community. If you know that, 60, 70% of your population that you serve is obese, you can develop the interventions, but you actually need to have line of sight and build that health equity lens into the work that you do every single day. And so we have a health equity center where we actually do look at all of that and provide information to our practices, whether it be obesity, severe blood pressure, whatever it might be, trying to really help improve health from a broader scale in the primary care space. But I really love Health Landscape. Check it out. You'll love it.
I will let others ask questions. If they don't, I will continue.
Dr. Yu?
Yes.
Dr. Schlund here. I go back to the value of simplicity that our solo small practice environment provides some of the most robust patient-centered care in California, and it's some of the most cost-effective. The area that I participate in, the CMA, we have 20% of the California population that is rural in small towns, where the systems and process complexity associated with ACOs just add expense without really value to these people, because entrenched in their small communities, they know everything about their patients. And that we have systems that have become so complex, they're actually killing people. Case in point, I sat in on a morbidity and mortality rounds where a patient went to surgery with critical aortic stenosis. Didn't go well. And it was lost in 38 other items that were on the problem list in the hospital information system, the EHR, that there's so much information and so much complexity that nobody could actually see what was right in front of them. And that my concern always about, complex multidimensional systems layered upon complex multidimensional systems is that they sort of create sometimes hazard instead of being helpful.
That's a really interesting thought. What we've seen is definitely, that is definitely a concern. What we've seen is the information that can be provided to certain ACOs actually helps mitigate that. Because, for example, we have a section in our app where it will tell a physician or a clinician, the staff, any diagnoses that have been billed for that patient in the past year, or 2 years, right? By any physician. It will tell you the diagnoses with who actually billed it. So you're able to catch those times of aortic stenosis was seen by cardiologists like a month ago, and it's highlighted there for you. That may not be in your EHR, right? And you may say, well, that might not be true. I don't think they have that. And you find out, no, they don't have that. You can dismiss it. You can say, no, that's not true. But that type of information and being able to track the information sort of concurrently with what you have in the EHR is very helpful to have line of sight of what's happening outside of the four walls of your practice. I think that that's the key, is that until we get integration to a level where everybody can see everything, in a very transparent way, and that the updated plan, right? The updated diagnosis list and an updated plan, like, I'm trying to figure out who owns that, right? There's a lot of discussion on that. That was one of exact points of discussion on the NQF call that I was on earlier this week was, what about that diagnosis plan? Shouldn't that be like part of all of this EHR care coordination thing? So CMS is looking at it from a much broader level of how do we ensure that everything is together. But you're absolutely right. And that's one of my concerns, is that a lot of physicians who are in rural areas, especially, who, if they have integration with a hospital and the patients only go to that one hospital, it's one thing. But if they go to another hospital, or they, you know, fly out of state and they go to Arizona or wherever else they go visit their family, if you don't have integration with everywhere, you're not going to see that. So
Yeah, no, hospitals
can help them with that.
Right. Hospitals try not to open their electronic information systems because they like electronic picket fences for economic reasons. And that, no, I hope and anticipate that we will get to, you know, open architecture, level playing field HIEs, where we can do exactly what you suggest. And I celebrate that opportunity with, you know, intelligent, you know, clinical decision support and all of the rest of the wonderments of the future. We're just not there yet.
Well, we're nearly there. Like, we're not there, but like, I'm seeing glimmers of hope. I really am. I mean, I wish I could share the app right now with you. If we meet together sometime, I'll be happy to share with you and show you what I'm talking about, because it is really hopeful. The information that's provided to physicians now, that is, I mean, even every swipe at Experian, you know, being able to know that your patient got a flu shot at CVS. I never knew that before, right? Now I know that. I know if they got a shingle shot at Walgreens or wherever. And that's kind of huge for me. So I know we're over time and I don't want Christy to yell at me. So I do hope that we will meet again at the installation event on April 6th. And I want to say thank you to all of you on the call, and for those who might listen in the future, thank you so much. And again, thank you so much, Christy. This has been fantastic.
Everybody got their questions answered?
Oh, you know me, Christy, but I'll wait till the other event.
Happy to answer your questions there. And also I will, my email address, I'll put right here. I'll put my phone number. You can always reach me. And we do have multi-specialty groups in Aledade. And
Dr. Yu, thank you truly very much. And I'm tickled that we're going to get the slide deck in advance.
Next time.
Yeah, it's a great talk.
Great. Thanks so much.
Thanks so
you all.
much, everyone.
Thank you for joining, and thank you, Dr. Yu.
Thank you so much.
Thank you.
Everybody take care.